Our panel discussion today, Building Better Crisis Response, Lessons from Arizona Behavioral Health Technology Solutions. My name is Melissa Lewis-Stoner. I'm the VP of Product Management at Relias, and we are a healthcare education company. I'm also a licensed clinical social worker, so definitely right where I feel like I belong. Behavioral health is still my passion. And as we listen to these behavioral health leaders that are right here from Arizona, local, I'd like each of us to just take a minute to recognize our common humanity, especially today. Our panelists are going to discuss how the state's pioneering crisis response programs are setting new standards in mental health care and meeting individuals where they are with honor and respect. Our panelists are going to share knowledge, experience, and lessons learned, and I'm going to hand it to Selena to start introductions.
Good afternoon. So I'm Selena McDonald. I am the Workforce Development Administrator with Banner Health Plans, which is one of the state's Medicaid programs.
Good afternoon. Johnny Gasper, Director for Crisis and Justice Systems with Arizona Complete Health, working as a regional behavioral health authority and overseeing crisis systems here within northern and southern Arizona.
And hi, I'm Franco Holleran. I'm with Mercy Care, the Regional Behavioral Health Authority for the Central Region of Arizona, and I am the Public Safety Coordinator for this area for the 3 counties.
Arizona has transformed its crisis system over many years. Their model emphasizes coordination and accessibility, as well as fiscal responsibility. By keeping individuals within the community and treating them in the safest and least restrictive setting, the crisis response system achieves better clinical outcomes and realizes significant cost savings, minimizing the use of expensive alternatives such as jails and hospitalization. Arizona is often referenced as an example, especially among Medicaid programs, for its innovative approach to behavioral health crisis services. They have a comprehensive array of crisis services available to all residents. These services promote hope and recovery, and many states are now looking to the Arizona model as they transform their own crisis care systems. The behavioral health workforce is at the core of the system, so we're going to start by discussing workforce development. Typically, health plans are very competitive when it comes to recruiting and staffing, as well as the services that they provide to their members. Selena, can you please share how competing health plans came together and collaborated to streamline staff onboarding and training?
Yeah, so first and foremost, we are guided throughout the state of Arizona by our various state policies. So under Access, which is the Arizona Healthcare Cost Containment System, our Medicaid program, we follow ACOM 407 and Attachment A, which basically requires us as Medicaid contractors to have a workforce development operation. So we have teams at each of the competing health plans that are responsible for overseeing the workforce across our network. So not necessarily within our own health plans, but those providers out in the community. So to do that, we follow those policies. If you want to go to the. So in that, it does state specifically that over the ACC, which is our integrated healthcare, our REBA, our SMI line of business, and our CMDP, so the children's services contractors, that we co-administer a contract between all health plans under what's known as the Arizona Association of Health Plans with a single statewide LMS vendor. So all 7, well, yes, there were 7 of us at the time, back in 2018, when this policy came out, we were required to collaborate in order to bring a single statewide LMS into the state system. So we hold a contract under AZAHP, and each of the health plans pays into that system. So we chose the Relias learning management system, and that is pushed out through all behavioral health providers. And it really helps us to streamline that. So we went from, competitors from day one to collaborators on day two, and making sure that our providers have that streamlined network. So just to give you an idea of what that looks like, we had those, right now we have 6 health plans. So one health plan did merge into another. So we started out as 7, we have 6. But if you look at that, we have the AZHP plus Relias are giving us that single statewide LMS. And if you want to, there we go. So we built a core training plan. So we have an onboarding or a NEO training plan that allows anyone coming into our behavioral health system under the Medicaid service to complete those training plans. So we have 9. And I'll say that before this streamlined process, we had almost 70 trainings required on an annual basis. So we were able to dig into policy, cut out what wasn't needed on a regular basis, and give them the very basics of what they need to get started. And then we left it up to the providers to determine what's needed to be competent. So rather than checking a box and saying that they've done a certain training, we're looking towards competency and letting the providers be autonomous in deciding when someone is competent. And then on an annual basis, you can see there that we have our annual training plan. So there is an annual requirement for some training. But again, we went down from 70-something to 6. So we're able to spread those out throughout the year. And anything beyond those 6, again, is up to the provider to make sure it happens.
And then how has technology supported those training initiatives?
Yeah, so it has been a really great thing to have that single statewide LMS. So one of the main points of having this is the portability of training. So I'm sure everyone's familiar with turnover and, an employee going from provider A to provider B or even more than that. So having this single LMS allows us to port the training over as they move throughout our system. So if they do leave one employer and go into the next provider organization, the training follows them. So they're all in that Relias LMS, and when they onboard, it allows for a faster onboarding process because the system accounts for what they've already done in their previous role. So we can onboard them at a quicker pace, and they're able to just get the job started. We want them seeing our members versus sitting down taking those trainings. So it really helps with that portability. And then it streamlines across the state. So if you have someone going from southern Arizona to northern Arizona or anywhere in between, they're taking the same training. So it doesn't matter where they go throughout the state, their training applies. And just to give you some snapshots here, a little bit of information that we've had. So this comes from Relias. We have some annual reports that they provide to us. So here in Arizona, we don't look at compliance. We know that everyone's busy, and it's really hard to really get you to get people to take the time away from their members to do the training. So we don't look at making sure you're getting it done on time. We just want to know that you're getting it done. So we look at completion rates. So you see that there's both a completion and compliance rate listed. We're doing actually exceptional on that completion rate. We're across the state on average, we're over the median for the industry. So we have that 96% completion rate across Arizona. And if you look at that bottom number, the usage rate, on average within healthcare, people are taking about 4.6 trainings throughout a system. Our employees across our network are taking almost 29 trainings. So they're doing more than what's required of them because of the system that we have in place. And again, this is another, that one's the same actually.
Okay.
We can go to the next one. And just a really quick overview of everything we're doing. So we're almost at 1 million completions total for training. So just think, being able to streamline this process, we've completed almost 1 million trainings in the few years that we've done this. We've had over 4,900 individual courses that have been completed during that time. We have, that number's a little outdated. This is a couple months old. But we have over 33,000 users in that system, and the intention is to eventually spread that across other lines of business, so not just behavioral health, but that physical health side as well. And as I mentioned, we're getting almost 29 completions per user, so everyone is doing a great job completing the trainings, and again, just having that technology in place is helping to streamline across the state.
Thank you, Selena. Super insightful, and I think it just goes to show what can happen when you collaborate across payers, across health plans to improve your workforce and to get on the same page. Next, we're going to move into another topic of interest, which is around physical co-location of behavioral health crisis responders at 911 centers. And so, Johnny, can you share a little bit about this approach and how behavioral health call responders were supported through technology integrations?
Yeah, happy to. So Arizona identified early on that getting police departments, fire, and EMS connected to behavioral health resources was advantageous, right? At that time, fire and EMS could only transport to emergency departments. Law enforcement only had opportunities to arrest rather than get folks into a 23-hour observation unit or request additional assistance. So we decided to try and move that forward. Where we started was, initially in 2015, crisis mobile teams and crisis dispatchers actually had to physically carry police radios all the time, 24/7. You rotated it between shifts and teams in order to access care. Obviously, from an efficiency perspective, if there's multiple calls coming in at once, if you're trying to gather data and information, it just doesn't work. Right? So to move that forward, we progressed and moved towards physical co-location, so adding folks directly co-located into the 911 Communications Center PSAP, so the public safety system. They will go through the same public safety training as well as go through the same training that we have at the crisis line through our 988 provider, statewide 988 provider here, Solari. And they actually are linked directly between the CAD, the computer-aided dispatch system that the PD has access to, as well as the crisis line's electronic health record. So we're effectively closing calls within the police department system so they know not to dispatch law enforcement, fire, or EMS, while also documenting on our side so we can auto-generate reporting for health plans and outpatient service providers. That certainly didn't happen overnight. It took us a long time to build trust, to get MOUs signed, and to ensure that this was implemented appropriately. Where we started in 2019, we actually took the time to look at the police dashboard. So all the calls waiting for service, you'll find that many PDs will tell you they're understaffed. There are calls of a lower acuity that wait for the dispatcher to say, yes, it's time to send someone to that. We started for callbacks for those nuisance calls, right, trespassing calls, things that were very low level and going to take hours for police departments often to respond. We did welfare checks, and what we found is the majority of those callbacks that we conducted actually required a behavioral health response. Over 80% of those initially on that outbound call. It was folks that were experiencing anxiety, folks that may be experiencing depression. The trespassing charges were for folks that are outside of maybe a gas station that needed services or help. So they really were our members in the community that needed that level of support. Next slide, please. So as we progressed forward, and through the COVID-19 pandemic, we actually tested a virtual co-location as well. So although our co-located crisis professionals weren't there any longer, we generated TFN, a toll-free line, that was directly connected to the folks that were cross-trained and had access to the CAD system prior to moving back to work from home, right? So they still had the same level of connection. They didn't have the physical component that existed before, but they still had access and linkage between both systems to close out calls effectively for the PDs, fire, and EMS, as well as for us. Next slide.
Yeah, can you provide an update and some lessons learned?
Mm-hmm. Yeah, so COVID-19 restrictions, as I mentioned, were difficult. The benefit of that is that we saw a spike in call volume when we added that toll-free line to ensure that we could access care 24/7. We had co-located staff there 3 days, we had 3 co-located staff there 7 days a week. But the gap was when they weren't on shift, the calls were rolling to folks that weren't cross-trained who worked just for the general crisis line. They didn't have the same level of familiarity, they didn't have the same access to CAD, and although call volume started to increase, we realized there was an additional service gap there, right? We needed to hire and cross-train additional folks that could also manage this program virtually as well as in person. This also became effective for our rural communities where we didn't have the capacity to co-locate folks in frontier areas, frontier police departments, or 911 communication centers, or those rural police departments or fire departments where their PSAPs might not be as connected to the general system, right? So by doing that virtually, generating new lines for them to connect to the staff that were cross-trained in their departments, we had the ability to take more calls without physically being in person to manage those calls 24/7. Next slide, please. And so this is where we are today. So in Pima County, the second largest county here in Arizona, down in southern Arizona, about 2 hours from here, we're managing through one partnership with Singular PSAP, around 800 to 1,300 calls per month transferred directly to that partnership. We dispatch at a rate of around just over 60%. Our stabilization rate for those calls, so folks that are stabilized telephonically versus sending a mobile team, is lower than what we see in our general crisis line volume. But when we've done some surveys, when we've talked to the police departments and the 911 operators, we really attribute that to folks just wanting an in-person response. What I relate this to is when my car gets broken into and they tell me file a report online, I still feel like somebody should have come out and taken pictures, right? And I think it's the same for folks that need that service and help in the community. We don't say no when someone wants a face-to-face response, and because of that, we do activate a lot more to those calls. However, once the mobile team is out working with those folks in person, the stabilization rate, so the folks that need inpatient versus those that can be stabilized in the community, remains consistent between the two populations. So that means, again, this isn't a higher acuity population. It's just a population that requires more face-to-face support because they're accessing it through a different system, right? We've also expanded now using the same model with CAD access and EHR access and physical co-location to northern Arizona, to Flagstaff, which is now averaging a few hundred calls a month transferred through them as well. And it is functioning and expanding in northern Arizona in their larger communities too. We've also expanded the virtual co-locations with the hopes that we can onboard new PSAPs and move towards a more statewide model and an opportunity to connect everyone to the crisis line a bit more effectively, rather than just using 988, which you might not get someone who's just familiar with your PSAP, your community, or the services that you have there.
Yeah, thank you so much. In addition to co-location, there's also 911 diversion. And this approach aims to reduce unnecessary police contact as well, and it connects people to mental health professionals when someone calls 911 and they're in a behavioral health crisis or they need some other social service. So Frank here is going to tell us a little bit more about 911 crisis or 911 diversion, what it is, why it matters, and do you have some tips for successful implementation?
Yeah, sure will. Just really quickly, if we could show the geographic areas, and Johnny mentioned some of them. They were there in the center, the Maricopa and Gila Pinal counties. It's a very large surface area. Pinal County alone is the size of Rhode Island, or Connecticut, sorry, with 14% of the population. So just give you some ideas. And as Johnny mentioned, Frontier, we have all levels of regions. We have urban, we have rural, we have remote, and frontier, and we have those in nearly every county. So this type of a program is essential for us. Next slide, please. Just really fast, these are different lines of business, and we're under the REBA, the ACC REBA. That's the Regional Behavioral Health Authority, and we provide services, crisis services, and SMI services, and some housing as well. And this is under crisis services. So the 911 diversion, it's really a simple program. It couldn't be any more simple. The 911 call comes in, and the communications dispatcher determines that the person has psychiatric needs only, and they transfer it to a crisis call taker at the statewide crisis line. Solari is our vendor for that. And again, it's statewide, but obviously they do the different regions. They do a warm handoff to the crisis call taker, the crisis call specialist, and they handle it from there. Next slide.
Maybe another slide. There we go.
Yeah, why would we do this? It's safer, right? And it provides a more appropriate response. Within that is whenever you don't have to send law enforcement to a call, you're going to have a safer response. That then as well is the more likely to get to the appropriate level of care. And really key is decriminalizing mental illness. I have a law enforcement background. I was a police officer for the city of Scottsdale for 25 years, and then I kind of fell into this because I was a CIT coordinator, the crisis intervention team coordinator for the police department in my last 9 years. And in that, learning how criminalized mental illness really is. We have far too many folks in jail and even in prison who are there because of their mental illness. And this is one of the things, this is one component of CIT that helps, very much helps decriminalize mental illness. And if for no other reason, it's economical. it's far more economical, right? It costs less to talk to somebody than to send even a crisis mobile team. Costs a lot less to send a crisis mobile team than to put somebody, have to have someone in a crisis stabilization facility. And fire, if fire were to respond, the likelihood is that person is going to an ED where they won't even receive any level of care for their psychiatric needs, and it's going to cost a whole ton more money than any of those other options. And then police. Now we train the police that if they find someone that needs psychiatric care, crisis care, that they can just bring them to one of our crisis facilities. That's great. That is a great option for them. Our drop-off times, this way in the South too, they're 1 to 7 minutes. That's all a police officer takes, and it's an open, it's a no wrong door policy. And what that means is when that police officer or fire EMS presents somebody at our door that's specifically for police and EMS, we say thank you, and we take that person. We don't ask questions. No one's turned away. So, and that's key. And then of course the quick turnarounds. That provides a better option than going to jail, right? So, how do you get this going? Well, there are barriers for sure. But as Johnny mentioned, you work with the police departments and mostly command staff, and of course, communications. Most communication centers are run through police departments. We do have one exception in Casa Grande in Pinal County that actually is done through their fire department. So it's really key to work with the command staff, but absolutely with the managers of the communications as well. All of these they all have different cultures, and it's really important to understand the different cultures too, or at least be familiar with one. I was honestly only familiar with PD, with law enforcement. Fire is very different. Folks from the outside don't recognize that, but even sometimes within the fire and PDs don't recognize that communications is a different culture as well. So it's really important to know that. And in the next phase, which is when you're going to train the communication personnel. It's essential, and to have someone from the world, if nothing else, than to interpret the language and the approach, because the approaches are different. We actually have one trainer who trains throughout the state, because we're with the statewide crisis line, Solari, Jennifer Bass, and she's amazing. And she comes from a dispatch background and a crisis call and a mobile team and a crisis call specialist background. She's the perfect fit to provide the training to the dispatch centers. The first thing is that the person has to do, obviously, is build a rapport with the communications staff. That's important for any instructor to their students. But with that, there is very resistant. All three of the cultures are very resistant from somebody from the outside saying, hey, this is why you have to do your job. This is the way you should do your job. But when she comes in, she's able to communicate that, hey, we're here to help you do your job. We're here to do your job more efficiently, and this is actually going to make your job easier. And what communications dispatchers are really important to them is that the fire and EMS and the law enforcement responders, that they're going to be safe too. So what we were able to communicate to them is this is actually a safer response for the first responders as well. In that, of course, you have to teach some psychiatric disorders to everyone. And just for a background, and just the ones that are the folks on the road that are actually the first responders actually run into the most. And then what's really important is what is that criteria? What will work to send? What is safe? What and liability is a concern? What is the safest? What is this person saying? And can they be transferred to the crisis line? And then embed that for at least a week while during that training. Those who are embedded, we have contracts as well, but we only have 4 agencies who are contracted. They have someone there from a crisis specialist, actually a crisis call specialist, actually in the dispatch centers. And then assist with policy changes. No one in any 3 of those cultures want to do anything unless policy backs them up in doing it. And writing the policy and getting that policy approved and working them through with that process is really important.
And then I think talking through just a couple of your lessons learned.
Yeah. Well, lessons learned, there's a lot of calls to be transferred. We're just with the 4 agencies, we're doing over 1,000 calls every month. And that contributes to the 41,000 times law enforcement alone brought us someone to our crisis system. 41,000 times in 2023, they brought us somebody into our crisis system, and this adds quite a bit of those folks. So, yeah, we're running at about 50% of the time somebody is stabilized. What we learned there is a normal crisis call that comes in is stabilized approximately 80% of the time. So we found that those folks are, and as I said, they might want someone in person, but we found that they were more acute folks calling into 911 than generally called into the crisis center. So, and here's a really big one. Yeah, sometimes calls have to be transferred back. They do, but because of the dangerousness of the situation. But that's 1% of the time. So 99% of the time, someone from public safety, and almost always that's law enforcement, doesn't have to go to that call that comes in. That's just an amazing data point that just, when you tell, especially when you're trying to sell this to chiefs of police and fire chiefs, they're like, what? 99? Yeah, that's right. And it's the best bang for the buck. In coming from that world and being an upper staff, I recognize that law enforcement doesn't have to ever go to those. They don't want to go to those calls in general. We have amazing CIT training, and of course, it's most of what my job is. But if they don't have to go at all, that's a huge plus for everyone. Yeah.
For the panel at large, what would you say for anybody in the audience that wants to think about starting this in their state or their community? What are a couple takeaways, then maybe some words of advice for them? And anybody can jump in, and then we can go through everyone.
I think if you have a CIT program active in your community, that's the best place to start, because that's where you're going to have buy-in automatically from whoever is sponsoring that CIT program. So CIT International, and if you're looking for it, there's obviously a website and there's an organization, and that's Crisis Intervention Team, and then there's training along with it, right? Because it's a five-component program, and having a robust crisis system and no wrong door policy and all those things and cross-training is all part of that. So if you have that in your community, that's the place to start, because there's already buy-in.
Yeah, I'd also add start developing the relationships with your police departments early, and that's because there will seldom be a police department, a fire department, or an EMS provider that doesn't feel like they need additional tools in their resource box, right? When we talk to the police departments, one of the things we hear a lot about taking these calls, sending these mobile team responses, is that these are the calls that burn out officers, that hurt fire departments, that make them not want to continue to go to the same call every day and day in and day out, right? Those are the calls from a behavioral health perspective we need to redirect into the crisis line, peer support services, crisis aftercare, get them enrolled in outpatient services so that we can decrease that volume on the 911 side too, because again, they're feeling that wear on their system as well.
And I would say a key takeaway is collaboration. So at the health plan level, again, we're major competitors in this industry, but we've set aside that competitiveness to be able to collaborate. And just collaborating on training alone has opened doors in other areas where we're collaborating across many different aspects of policy and how to put things out to providers to really help them and provide resources. So remove that competitive nature, understand you're working in the same communities and working with the same people half the time. So working together is key.
Thank you. I'm going to open it up to the audience if there are any questions. I don't see any on the app, but if there are any questions for folks, yes.
I'm just wondering about any connections to schools or youth and families. Like, could y'all expand on that?
Yeah, so the question was, are there connections to schools and/or families?
Yeah, I'll start by saying we're certainly connected to school resource officers. We also co-locate outpatient service providers in our school districts. That's been really beneficial because initially we did see high crisis response during testing season and right when school started again. The reason the outpatient providers are there is they have the capacity to develop relationships with the counselors so we can be a little bit more preventative in our response to the school districts. We also offer CISM, critical incident stress management, as well as psychological first aid for acute events that occur on campus. So anything like a student death, we're there as well to support the system. But again, the thing I'd highlight the most is the outpatient resource, the connection to counselors and students as well as teachers allowed us to be a lot more preventative and decrease some of the crisis response. Not that we aren't connected there, but it's been more largely beneficial, in serving the community better.
Anything to add? No? Okay. Yes.
For Selena, for the Relias, how did you guys appropriate funding for that? Is it cost spread across all the different employers? Is it state funded, et cetera? I'm familiar with it. We've used it with our CCBHC partner. But my facility, my health system is not able to use it because we're not part of the CCBHC. Kind of told us about.
Yeah, so the question was for Selena, and how is the learning management system funded, and
Yeah, so we have Arizona Association of Health Plans kind of oversees all of the health plans in Arizona, the Medicaid system. So they hold the contract for Relias, and each of the health plans pay into that contract. And right now, I believe we pay by member lives. So the number of member lives per health plan is the proportion that we pay into that contract. And the providers pay nothing of that unless they have to maybe customize a portal. But the health plans take on that cost.
and so all the organizations under the health plans are part of that?
Yes, any behavioral health provider, we do have requirements based on their provider type, how they are credentialed and contracted with their health plans. There are specific provider types that are allowed in the system. And so they can get a free portal, a small portal if they're a small provider. And if they need a larger one, they do have to pay an implementation fee. And then they can pay to customize if they choose to get anything beyond what we have. But we pay for the libraries that are currently available, and we pay for the enterprise itself.
Yes, any other questions? I'll go to the gentleman in the back, and then we'll come up to you. Yes, you?
Hi. I'm just curious about the introduction of 988 and any challenges that you see with interoperability in the state?
Yeah, so the question was around the introduction to 988 and interoperability within the state.
I'll kick it off, and I'll say initially in Arizona we were concerned about geolocation. When 988 was linked to your cell phone area code, right, since the Arizona system had progressed to a point to have, a singular statewide vendor at that point as well, and again had the ability to dispatch, we did not market as much 988 because we did have concerns since we have military bases, a large number of tribal communities here, as well as folks that travel here during the summer and winter months. We marketed a little less because our fear was that it would be transferred to a different state and it would create a lag then to get access to like a mobile team or the services you needed in the community. Presently, no, it's functioning directly under that singular statewide line provider. So our statewide crisis line is run through Solari. They're the statewide 988 provider. The linkage is relatively seamless. We still operate, again, the dedicated toll-free lines that connect into the 911 system. But if you're like an officer on site when you're responding to a community member in the field, there's no difference between calling your local crisis line number, the statewide crisis line number, or 988.
Anything to add?
Yeah, that was great.
Okay. And the gentleman there?
Couple questions. On the geo tracking, are you doing any of that internally just for the safety of your own staff that's on location?
So the question is around geo-tracking, and are you doing any of that internal?
Yeah. Yes. So yes, the statewide crisis line handles the dispatch of the crisis mobile teams, and they use GPS for the locations, and they know the locations that they're going to.
Yeah, I'd add that we've piloted it 2 different ways. There was physical hardware installed in the vehicles for a period, and we've done cell phone-based geolocation as well. So we have interoperability on both sides.
My next question was, in the data presented up here, do you have any data that support kind of the type of call of age-wise 17 and under versus 18 and over?
Yeah,
We-
within the data that was presented, just supporting 17 and under, 18 and over.
Yeah, we sure do. I apologize, I don't know that off the top of my head, though, but yeah, it's available.
Yeah, so I'd say from the 911 transfer project anecdotally that it's a small subset. By comparison, school-based utilization is a little bit higher. We get 911 calls there that are linked and connected then to crisis, but individuals calling directly into 911 with the mental health crisis are more limited. We generally see parents and families. Our primary caller is self, right? So individuals calling the crisis line from themselves, but those are individuals over the age of 18 more often than not.
Do you have another question? Or those? Okay. Any other questions from the audience? Okay, I'm going to ask the panelists for kind of last words for the room. And we'll start with you, Frank. You can come this way.
Yeah, I would just like to repeat that the 911 diversion is the best bang for the buck to keep law enforcement and fire doing what they do better, and not because they can work with folks in crisis very well, but what they do better and what you're actually paying them to do. So if you need a program locally, this is the one to sell.
Yeah, I'd add that I know that our funding structure is different here. We're lucky to have Medicaid and blended dollars that allow us to function and operate a crisis system that is this robust, allowing everybody to have access. But what I'd say is the way to market this to health plans and additional payers is to highlight that, as Frank mentioned in his presentation, this is both clinically appropriate as well as cost effective. This is where things really marry together nicely. One of the few times that health plans will come to the table and agree that accessing a lower level of care that is clinically appropriate is also going to benefit us, right? And that's a large selling point in communities where you might not have those braided dollars or that funding coming from Medicaid. As you pursue that, whether it is at a county, a state level, or even a city level, those are the discussions that need to be had with the local health plans as well as the providers that are going to be rendering these services.
And I already mentioned it, but that collaboration, that's very important, but also streamlining. So looking at ways you can work with your other community partners to streamline what you currently have in place, and just make it more effective across your communities. What we've seen with this training being streamlined and portable across all of Arizona's needs or areas, it's just been effective overall. We were able to really get the training out there. We're able to count it no matter where they go, so they don't have to start from scratch if they move into a new position. So streamline, collaborate, and just work together.
And I think my key takeaways from working with these three is not only the clinically relevant care where the person is and when they need it, but getting folks like first responders back out for the calls that they are needed on, and have, the behavioral health folks really meet the people where they are and where they need services. And so I think those are the big selling points in communities, is making sure that law enforcement, fire, rescue, EMS is out there for those types of calls, and then behavioral health providers can help those that are in behavioral health crisis. So thank you. If there's no other questions, and certainly we'll be up here for a few minutes to take any questions or to talk offline. Thank you.